ఉంటా.
Cool. Welcome back and good morning, everyone. I think I am audible and visible right now. I think a few candidates are already there. And am I audible and visible? Okay. Cool. Yeah. I am audible and visible. Great. Fantastic. So let us start with the session for the day. What we are going to do is to start with UJ bleed. I think I told you the first topic will be UJ bleed. Then after half an hour, maybe we can move on to viral hepatitis after that. So what we are going to start is with UJ bleed. So as far as upper gastrointestinal bleed is concerned, you have many different causes for upper gastrointestinal bleed. And one of the very important causes of upper gastrointestinal bleed is going to be the peptic ulcer disease. Because if somebody asks you what is the most common cause of upper gastrointestinal bleed, I would answer that it is peptic ulcer bleed. That's going to be the most common cause, basically. So, but nevertheless, so not only the UJ bleed, let us discuss on some of the causes of lower gastrointestinal bleed as well, because we are on the topic of gastrointestinal bleeding. So that's why. So I'm going to divide the causes of UJ and LJ bleed into maybe 2, 3. So first, the most important cause are erosive and inflammatory etiology. That number one, erosive and inflammatory etiology, which is typically the most common. In erosive and inflammatory, the number one cause, of course, is going to be the peptic ulcer disease. This is the most common cause of upper gastrointestinal bleed for that matters. And you can get with erosive gastritis or esophagitis, not just peptic ulcer disease. It could be a gastritis or duodenitis or even esophagitis. So this also could cause upper gastrointestinal bleed. But remember, almost 30% of all upper gastrointestinal bleed cases will be due to underlying peptic ulcer disease, and that's supposed to be the most common cause of upper gastrointestinal bleed for that matters. And LJ bleed, the most common erosive inflammatory cause is diverticulosis. And once again, this contributes to almost 30% of the cases of lower gastrointestinal bleed, which means this is the most common cause of lower gastrointestinal bleed. So these are the 2 points that you need to know. So one is peptic ulcer is most common cause of UJ bleed, and second one is diverticulosis, which is the most common cause of LGI bleed. And apart from that, IBD. But which IBD usually causes LGI bleed? Is it ulcerative colitis, or is it your Crohn's disease, which will cause lower gastrointestinal bleed very commonly? Ulcerative colitis or Crohn's disease? Excuse me. Yes, ulcerative colitis. Ulcerative colitis is the one that typically causes lower gastrointestinal bleed, and Crohn's disease most often comes with kind of diarrhea, constipation, strictures, pain, mass. So this usually fistulas usually goes towards Crohn's disease. Tenesmus, perrectal bleed, like hematochezia, like fresh bleeds and all these things goes towards ulcerative colitis. So lower gastrointestinal bleed is more common with ulcerative colitis than that of Crohn's disease, and sometimes infectious diarrhea, like certain conditions may result in development of bloody diarrhea. So that can result in lower gastrointestinal bleed as well. But nevertheless, you have multiple different causes. Number 2, you have some vascular causes of UJ as well as LGA bleed. As far as vascular causes concerned, the number 1 vascular cause is varicose bleed. So, varicose bleed usually happens in patients with liver disease, but it can happen in patients without liver disease as well, as we saw yesterday, in the form of MCPF, or probably some conditions like EHPO, where you don't have a liver disease really, but still you develop varicose bleed. So varicose bleed is quite common in those situations, but most commonly with liver disease. And if at all, if somebody asks you what is the second most common cause of upper gastrointestinal bleed in the world, answer will be varicose bleed only. And you have 2 types of varicose hemorrhage. One is esophageal varices, and we also have the gastric varices. But of course, esophageal varices are quite common compared to the gastric varices, which we'll be discussing in some time. And at the same time, we have something called as a diaphragm lesion. Diaphragm lesion, which also will be discussed if there is time. But most importantly, we are going to discuss the varicose bleed and the peptic ulcer bleed, which are going to be very important. And vascular causes, lower gastrointestinal hemorrhoids are supposed to be the most common among the vascular causes of lower gastrointestinal bleed. And you have ischemia, like for example, mesenteric ischemia, ischemic colitis. Example is ischemic colitis, mesenteric ischemia. All these things can result in development of lower gastrointestinal bleed. And we do have something called as rectal varices. Rectal varices. And we also have something called angiodysplasia. So usually it is very common in the colon. So colonic angiodysplasia. It really does not, it can cause, actually angiodysplasia can be a cause of both lower gastrointestinal as well as upper gastrointestinal bleed. But angiodysplasia is quite common for causing lower gastrointestinal bleed than upper gastrointestinal bleed, because it's more commonly located in the right side of the colon, especially in the ascending colon. That's what we typically call it as a right-sided colon. 70% of the times it will be located in the right-sided colon only. And if somebody asks you what is the most common vascular cause of lower gastrointestinal bleed, it's going to be angiodysplasia. And most common cause of lower gastrointestinal bleed is diverticulosis. Most common vascular cause of lower gastrointestinal bleed is colonic angiodysplasia. Usually common, what are the clues towards the colonic angiodysplasia? There are quite a few things that they will be asking in exams. One is, it's common in extremes of age itself. In old age itself, it's quite common. And second is patients who are suffering from end-stage renal disease, quite common. And third is patients who are suffering from von Willebrand disease. And fourth is patients who are suffering from aortic stenosis. So these are the 4 things. But in exam, usually your question will be based on aortic stenosis. A patient who's having aortic stenosis developing a lower gastrointestinal bleed. So what do you really suspect? Answer is angiodysplasia. Very common question in exam. And what is that disease called as? Is there any special name for the disease? The question is for the audience, so you can answer. So what is the special name? If you have aortic stenosis with colonic angiodysplasia, so what is that name called as? What do you mean by that? What is the special name given to that syndrome? Yes, as many of you are answering, Ankit has answered correctly. That is Hades syndrome. So that's the name given for that. So a patient who's having a colonic angiodysplasia, and having a lower gastrointestinal bleed is supposed to have something called as Heyde syndrome, HEYD. So that's the name. So fine. So these are the usual things. So there are 4 points which are very important. Most common cause of UJ bleed, peptic ulcer disease, most common cause of LJ bleed, diverticulosis, most common vascular causes. Second most common cause of UJ bleed is variceal bleed, and most common vascular cause of LJ bleed is angiodysplasia, then followed by hemorrhoids. Then what about third category? Third category are the tumors, which are very, very important. So tumors rarely will cause acute bleeds. More often they will cause chronic bleeds, leading to iron deficiency anemia. So that's when an elderly patient coming with iron deficiency anemia, you have to really be careful in ruling out a carcinoma, especially of the GI tract. So, but sometimes, very, very rarely, they can produce acute bleeds also, like esophageal and gastric carcinoma. But please take with a pinch of salt. Esophageal and gastric cancers also cause chronic bleeds, and they will produce more of iron deficiency anemia, but rarely they can produce acute bleeds. And colorectal cancer. And we know any colorectal cancer can produce bleeding, but usually, like theoretically speaking, it's the right-sided cancers that often causes bleeding compared to the left-sided cancers. You would have studied in your pathology. So even though that is not 100% true, but most of the times the right-sided cancers generally tend to produce bleeds, and left-sided cancers generally tend to produce your obstruction. So that's how it is, but not always true, not 100%, nevertheless. And you can get with the trauma, local trauma, traumatic bleeds are there. So for example, the best example for traumatic UGA bleeds are Mallory-Weiss tears. I think we have discussed this in the cardiology section itself on the topic of chest pain. And LGA bleeds traumatic usually will be iatrogenic, either following a procedure or following a surgery, like after a polypectomy or a colonic biopsy, or after a anastomotic surgery. Post-anastomotic bleeding is there. So when you resect and anastomose 2 segments of the colon with each other, so most often it will be post-operative or post-procedural or iatrogenic in nature. So that's the usual reason for getting a lower gastrointestinal bleed. The upper gastrointestinal bleed very commonly will be due to Mallory-Weiss. We have discussed already. And we have some other miscellaneous causes for developing UG and LGA bleed. For example, you have anal fissure, which usually causes severe pain, but generally does not cause bleeding, but most often they cause pain. That's that presentation of anal fissure usually. And for the UGA bleed, you can think about portal hypertensive gastropathy, which typically is a complication of a portal hypertension, especially a chronic portal hypertension. Portal hypertensive gastropathy. Most of them will be treated only conservatively. There is no definitive treatment for this. You have to reduce the portal pressure. Automatically, the portal hypertensive gastropathy will come down. And anticoagulants can be a cause of both the UGA as well as LGA bleed. So it can be written on both sides. Especially in the presence of underlying gastrointestinal disease, anticoagulants tend to cause bleeding. For example, if they have already peptic ulcer disease, anticoagulants tend to exacerbate the bleeding caused by peptic ulcer disease. So what are the presentations of UGA bleed? Suppose if somebody asks you what are the clinical features, how they will present. So remember, first of all, you need to understand that both UGA as well as LGA bleeds can present with iron deficiency anemia. So if at all they are chronic, they generally come with iron deficiency anemia. If they are acute, they are going to present with certain features like hematemesis or probably a melena. So, but here, if they are acute, usually they present with hematochezia, that is a fresh bleeding per rectum. So that is called hematochezia. Please understand that hematemesis, melena can happen in a LGA bleed. At the same time, hematochezia can be due to upper gastrointestinal bleed, but these cross combinations are quite rare. Usually, hematemesis melena means it's a upper gastrointestinal bleed. Very, 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 very rarely, there are some cases which have been proven to be originating from a lower gastrointestinal source, but very, very unlikely. Whereas hematochezia is usually a lower gastrointestinal bleed, but extremely rarely it can be a source. It can be coming from a upper gastrointestinal source as well. So to produce melena, you know very well that it needs some time for the blood to be oxidized. Then only you can produce that black tarry stools. The timing is very important for how long the blood should remain in the gastrointestinal tract to produce that kind of black tarry stool, so that the hemoglobin will be oxidized by the gastric acid to produce that black tarry nature. So what is the number? So typically it takes around 5 to 14 hours minimum. So this minimum time the blood should be in the gastrointestinal tract to produce, this black tarry nature. So otherwise you won't get melena. So that is the reason why if the gastric motility is too high, sometimes, suppose if the gastric motility is too high, and the blood is not having sufficient time to stay within the gastrointestinal tract. So for example, because the high gastric motility and high intestinal motility, if the blood is pushed to the lower part of the intestine within a period of maybe 2 hours, so then you might result in hematochezia also. That is why very rarely upper gastrointestinal bleeding can result in the development of hematochezia. If the intestinal motility is too high or too fast, you might not really result in development of melena. So anyway, so we don't want to discuss that controversies, but nevertheless, UGI typically causes hematemesis and melena. LGI bleed typically causes hematochezia, and both of them, if they are chronic, they can result in blood loss and iron deficiency anemia. But what is the definition of UGI bleed, by the way? We didn't discuss about that at all. Anatomically, there should be some definition which separates the upper gastrointestinal bleeding from a lower gastrointestinal bleeding. UGI bleed are ones that originate proximal to the ligament of Treats. Ligament of Treats is the anatomical landmark to separate the UGI bleed from LGI bleed. So proximal to the ligament of Treats, which is also referred to as suspensory ligament of the duodenum, which is usually located at the duodenojejunal flexure, if I am not wrong. So that is the position, that is the place where you really define the location for the upper gastrointestinal bleed. So if the bleeding is distal to the ligament of Treats, which is present at the DJ flexure, ligament of Treats, then these bleedings will be typically referred to as lower gastrointestinal bleed. That's the anatomical difference to tell whether it's a UGI bleed or LGI bleed, which is a very common question asked in exam. So whenever a patient comes with a UGI bleed, so what is the algorithm for evaluating them? So first of all, tell them whether stable or unstable. So I'm going to see the hemodynamic stability first. If they are hemodynamically stable or if they are hemodynamically unstable. If they are hemodynamically stable, I'm going to do endoscopy, UGI within 24 hours. So within 24 hours, the key here, the patient is hemodynamically unstable. So I'll be doing endoscopy as soon as possible, ASAP. There's no time limit for that. So I'll be doing endoscopy ASAP, but it should be always be done after the initial stabilization. Of course, the patient is unstable. So initially you need to stabilize the patient with fluids or blood products. Once the BP and hemodynamics are stabilized, then I can do endoscopy ASAP, but there's no time limit here. So you have to do endoscopy as soon as possible. So then you have to ask the question whether source is identified or not, which means the idea of doing an endoscopy is to identify the source. So source is identified or not is the question here. So if the source is identified, then you can go for specific treatment because you know the source of the bleed, like varicose bleed or probably maybe angiodysplasia or maybe peptic ulcer disease. You know the source now, so you treat accordingly. The source is not found, then it's better to go for colonoscopy, because rarely UGI bleed can be found in the lower gastrointestinal area. So I told you that point. So that is the reason why colonoscopy is done next. Suppose if still source is not found out, so which means even if colonoscopy is normal, still if the source is not identified, then you need to evaluate for small bowel bleeding, because the bleeding source can be coming from the small bowel at times. So you have to think about colonoscopy is also normal. So the colonoscopy is abnormal, shows some source, then you can go for specific treatment again. The colonoscopy is completely normal, then you have to think about the possibility of small bowel as the source. Very rare, but still potential. Small bowel as a source of bleeding. Then we have multiple other choices like enterography, then CT, angiography. So many other investigations are there which are a little cumbersome for your level, so it's not needed. So right now, the idea is that you can think about a small bowel as a potential source of bleeding. So most of the times your source will be identified. It's not like source is not identified. Most of the times your source will be identified and you can provide a specific treatment for upper gastrointestinal bleeding. Most of them, 98 to 99% of the times your source will be identified in your routine endoscopy itself. And one of the most common causes of upper gastrointestinal bleed is peptic ulcer bleed. So based on the endoscopy, the peptic ulcer disease bleeding, the peptic ulcer bleed can be categorized based on the endoscopic appearance. These are called as Forrester grading or Forrest classification. This is called as Forrest classification. And sorry for the wrong name, Forrester grading. Forrester grading is for the cardiogenic shock after myocardial infarction. So I think I would have told that, but this is called as Forrest classification. So based on Forrest classification, you can divide the bleeding ulcers into three. Yeah, you can put as grade 1, or you can put as grade 2, or you can put as grade 3. So grade 3 is the most simplest form. This is the cleanest ulcer base, which means it's unlikely to be a source of bleeding, which means there is an ulcer, but there is, of course, there is no evidence of bleeding as per the endoscopy. That is called a clean ulcer base. Then we have grade 2. Grade 2 are the ones which have some recent stigmata of bleeding, which means there is signs of, we call it a stigmata. So either stigmata is there or signs of recent bleeding is there, which means it's not bleeding actively, but no active bleeding. So it has bleeded recently, blood, but there is no active bleeding at present. But there is some signs that you can look in the ulcer that tells you that there was recent bleeding, but there is no active bleeding right now. And class 1 are those ulcers which have active bleeding right now. So when you do endoscopy, that is the time where you are seeing actively bleeding from that particular ulcer. That is class 1. So of course, class 1 has the highest risk of bleeding, rebleeding rates. There is nevertheless nothing to tell in that. So they are going to have the highest risk of rebleeding. And one is again divided into 1A and 1B. Suppose if you want to know what is 1A, 1A is active spurting of bleeding, which means there is pulsatile bleed that is spurting out, which means some artery is broken, and from the ulcer, that ulcer has eroded some artery, and there is a spurting pulsatile bleeding from that particular artery. And you have 1B. Class 1B, you don't have a pulsatile bleeding, but the blood is coming in a oozing fashion, oozing bleed, but it's non-pulsatile. So of course, the highest risk of rebleeding is with class 1A only, and there is highest risk of hemodynamic instability is also with class 1A only. And class 2 again can be divided into 3: class 2A, class 2B, and class 2C. Class 2A typically we refer to as something called as non-bleeding visible vessel, which means there is a vessel that can be seen over the ulcer, but it is right now not bleeding, but it must be the source of the bleeding. So that's called a non-bleeding visible vessel. And 2B is called as adherent clot, which means clot is an example of a recent bleed, which means that area is sealed with a clot, but still, so that's a stigma of recent bleed. And 2C is called as flat pigmented base. It is almost equal to that of the clean ulcer base, but it was a remote bleeding evidence, but everything is clean at that point. So it's a flat pigmented base. It's a clean ulcer, except for the fact that it is pigmented a little bit. So still it has a little risk of bleeding, but not compared to that of the other classes. It has a very low risk of bleeding. 3 is only one that is a clean ulcer base. So these are the Forrest classification for endoscopic grading. But remember, what to treat and what not to treat is very important. So this class 1A, 1B, 2A, 2B is basically referred to as high risk stigmata, which means these are considered to be extremely high risk for recurrent bleeding. So these patients has to be treated. 1A, 1B, 2A, 2B has to be treated. And this 2C and class 3 need not be treated. Generally, we don't treat them. So just the routine stabilization protocols are enough. You don't really need to treat this 2B and 2C and 3 endoscopically. So what is the endoscopic treatment that is advocated? There are three endoscopic therapies are there. One is epinephrine injection, second is thermocoagulation, third is hemoclips. But the current guidelines recommend you have to use epinephrine injection, that is mandatory epinephrine injection. Plus at the same time, you should give any one of the following two which I'm going to tell. For example, other techniques are, we have something called thermocoagulation, and second one is hemoclips, which are ready-made available. So out of these two, any one you have to try. So this is the current guidelines recommending. So I mean, this is the way to reduce the risk of rebleeding to substantially low extent. So the dilution of epinephrine that you're going to use is 1:10,000. Locally, you're going to inject the epinephrine, and you will actually inject into the 4 surrounding quadrants, and to produce a local tamponade-like effect. The total amount of epinephrine that will be injected is approximately 13 to 20 ml, which is available currently in aliquots as well. The dilution that we use is 1:10,000 for injection here. So epinephrine injection is mandatory, followed by hemoclips. This is the usual procedure followed in our hospital most of the times. But epinephrine injection alone is considered to be extremely inferior. So if you want to follow only one procedure, then probably you can give any one of thermoclips or thermocoagulation or hemoclip, but epinephrine injection alone is considered to be one of the worst methods to control the bleeding. So always give epinephrine injection, which will control the bleeding, but still as an add-on, you have to give either thermocoagulation or hemoclip. Any one of these things should be followed. So this is the current guidelines, so which has the lowest risk of rebleeding after this. And apart from that, there is something called sclerosant injection, which we sometimes use in varicose bleeding, but sclerosant injection is basically not recommended in patients with peptic ulcer bleeding. For peptic ulcer bleeding, definitely you should not do sclerosant injection. You can do that in varicose bleeding, but sclerosant injection is not the right method of choice for treating a peptic ulcer bleed. So I told you, you will be stabilizing the patient, isn't it? You will be stabilizing the patient. So this is something done. One of the important methods of stabilization is IV proton pump inhibitors. So this is something very, very important. Almost all the patients will receive IV proton pump inhibitors, and it will be given for at least 72 hours post endoscopy. So you will start pre-endoscopy itself, but please understand, even after the endoscopy, it will be continued for 72 hours post endoscopy, which has been shown to reduce the risk of bleeding. So all upper gastrointestinal bleedings, especially if it's a peptic ulcer bleeding, definitely they should receive IV proton pump inhibitors 72 hours post endoscopy. Especially this is applicable for peptic ulcer bleeds. But it is extrapolated for every single UGA bleed. Every single UGA bleed you can give IV proton pump inhibitors. But for peptic ulcer bleeds, it's a special recommendation. Definitely they should receive, like for 72 hours post endoscopy, which is a very important point. So even though I've told you no treatment here, which means here I mean no treatment means I'm meaning the endoscopic treatment is not done. It doesn't mean that you will stop all the treatment. Still, these patients will be receiving IV proton pump inhibitors for 72 hours after the endoscopy, even if you don't do any endoscopic treatment. So that is something you have to keep in mind. So this is the Forrest grading and how you really identify the source of bleed and treat accordingly depending on the risk of rebleeding. And then you have some other lesions which may be important to know. So one is the Dialophoid lesion. Dialophoid lesion. So Dialophoid artery, there is something called Dialophoid artery. It is a dilated submucosal artery. So what is the usual location? So I'll tell you some clues. So either it's located in the pylorus Dialophoid artery, or it's located in the lesser curve fundus cardio-esophageal junction. So which is your take? So where it is commonly located, the Dialophoid artery, which is the most common location? So that's a question, isn't it? Dialophoid artery, which is the common location? In the stomach, of course. I told you all the 4 areas are in the stomach. So where it is located? No idea. It's not located in the GE junction. It is typically located in the fundus. So that is where the usual location. Usually 6 centimeters from the esophagogastric junction. It's very difficult to identify because it's a very diffuse thing, and it's not associated with an ulcer. So sometimes you might be needing endoscopic ultrasound and Doppler and all to find out the culprit vessel here. So it's very difficult to find out in reality. And most often in the exam, the clue will be it causes something called intermittent bleeding. This is the clue. It will cause something called an intermittent bleeding. So this is the clue most of the times, but it can be very significant and massive. And treatment as such, you are going to use routine endoscopic therapy. So like what I've told you before, like epinephrine injection, thermocoagulation, hemoclips. So even banding and ligation is also tried in certain situations, but routine endoscopic therapy is the thing that is indicated in patients with Dialophoid lesion. But it's very difficult to find out. So you might be needing endoscopic ultrasound or Doppler sometimes trying to be the culprit vessel. It causes intermittent bleeding. There cannot then, sometimes there won't be any stigmata at all because it's just a vessel that is in the submucosal area. Remember, first of all, what do you mean by Dialophoid vessel? It is a dilated submucosal artery. That's all. Submucosal artery. And once again, they'll be asking you whether it is submucosal or mucosal or muscularis mucosa. These kind of things they might be giving you in the exam. So it's submucosal intermittent bleeding located fundus 6 centimeters from the esophagogastric junction, very common location. Malarious tears we have discussed already, classically associated with retching and vomiting. Malarious tears, it's a partial tear. We have discussed already in the cardiology section. It's a partial tear. it can be easily treated with endoscopy. And the most common location, if they ask you for malleolus tear, is the cardia. That is the most common location, cardia of the esophagus, especially at the lesser curve, lesser curvature. So that is a common location. Most common precipitating factor is alcohol, and it can happen in some patients with bulimia nervosa also. So the reason is vomiting and retching of unrelaxed cardia. So that is the reason for developing malarious tears. And most of the time, the bleeding will be self-limiting. It won't have any problem. Yes, we have discussed that already. And there are something called Cameron solution, which I don't think it's very important for you to understand. Usually, most of the time, Cameron solutions will cause only occult GI bleed. Occult GI bleed, which results in iron deficiency anemia. This is the most common way of presentation of Cameron solutions. It's very, very, very rare to get. And number 4, you have something called gastric antral vascular ectasia, that is called GAVE. In exam, what are the conditions that are associated with GAVE? GAVE is otherwise referred to as something called a watermelon stomach. So you will have this kind of stripes of ectopic mucosal vessels. So you can see in the stomach like that, there is something like stripes of ectopic mucosal vessels. Usually these are venules. Basically, these are not arteries, which typically results in production of iron deficiency anemia again. Usually they don't cause very severe acute bleeds because it's veins, so they don't cause that massive torrential bleeds. So they generally cause more of a chronic bleed and iron deficiency anemia because of these stripes, which I've told you. These are ectatic venules that are seen as stripes in the stomach. So that's why it is, the name has come, that is called as a watermelon stomach. And GAVE is very common in the setting of portal hypertension, number 1. Very common in the patients with cirrhosis. And second, in patients with end-stage renal disease. And third, in scleroderma. But what they will ask you in exam is regarding to the scleroderma. So this is a very common question in exam. One of the important reasons for iron deficiency anemia and chronic occult bleeding in scleroderma patients is this gastric antral vascular ectasia. Remember, usually associated with slow bleeds, slow UGA bleeds, which means occult bleeding resulting in iron deficiency anemia. This is the commonest presentation. Usually that kind of massive UGA bleeds are very rare. Acute bleeds are very rare. Usual treatment, they will ask you again. So in a patient with scleroderma, known case of GAVE, what you're going to treat? The most common treatment that we use is endoscopic argon, plasma anticoagulation. Endoscopic argon plasma coagulation is the first line. Because the most common location is the antrum, that is where GAVE is located. You can do antrectomy in refractory cases, but it is not something that is tried in all the patients. Usual first line therapy is endoscopic argon plasma coagulation. So that is the most common therapy that we follow. Then we have portal hypertensive gastropathy, which is due to portal hypertension, portal hypertensive gastropathy. Usually, again, they will result in chronic blood loss and iron deficiency anemia only. Typically, you have to reduce the portal pressure. Treatment is to reduce the portal pressure, maybe with propranolol or TIPS. That is going to be the treatment which I have discussed yesterday in detail. So that is something we're not going to discuss again. So then we have the 6th etiology of upper gastrointestinal bleed, so which is very rare. That is called hemobilia. Hemobilia. So in exam, if they ask you where will you get hemobilia, usually hemobilia is post-procedural. Post-procedural means after some biliary procedures. So like for example, after a ERCP, very common example is post-ERCP. This is the usual history you will get in exam. Or you can get after a TIBS or after a percutaneous transhepatic cholangiography, that's called PTC. So some biliary procedure will be there. After this, you will get this characteristic triad. So what is the characteristic triad? You're going to get triad of UGA bleed, then you will get obstructive jaundice, so that altered LFTs will be there, direct bilirubin will be very high, and you will get a characteristic biliary colic because this blood in the biliary tract is going to obstruct the bile from flowing, and that's why result in the pain. So the biliary colic. And what is this triad called as? Any idea? Anyone knows what is this characteristic triad of hemobilia is called as? What is the hemobilia triad here? Is there any name for that? Yes, you have a special name for hemobilia triad that's called as a Quincke's triad. I mean, you would have studied that Quincke's nail sign in patients with aortic regurgitation, but This is a Quincke's triad, that is a triad of hemophilia. Treatment mostly is conservative. You just wait. Most of the times it will resolve. It's not a problem at all. But sometimes you need to do something called arterial embolization if the bleeding is uncontrolled and it's causing hemodynamic instability. But most of the time, bleeding will be controlled over a period of time and everything will settle down smoothly. So no need to treat. It's only conservative treatment. And then we have another type called as hemosuccus pancreatitis or hemosuccus pancreaticus. Hemosuccus pancreatitis. It's a very rare cause of UGA bleed. It is usually the reason for getting this hemosuccus pancreaticus is some pancreatic pathology, like probably a pseudocyst, or after doing an ERCP or manipulating the pancreatic duct in that scenario. Very commonly in exam, if at all they ask, they will be asking you a pseudocyst causing a bleed. What is the name called as? That is hemosuccus pancreaticus, a pancreatic pseudocyst causing a bleed. So usually, where is the bleeding source? Whenever you use a side viewing endoscopy, the bleeding source can be identified very easily. The bleeding source will be bleeding will be coming from the pancreatic duct, and the bleeding will be oozing out of the ampulla of Vater. So that is a characteristic finding. So whenever there is a bleeding from the ampulla, there are two sources. Please understand. Whenever bleeding is there from the ampulla, there are two sources. Either it could be a hemophilia or it could be a hemosuccus pancreaticus. So in exam, if they give bleeding is coming from the ampulla, and if they ask you the diagnosis, so what is the probable diagnosis, then look at the prior history. Either the patient is having a biliary pathology and you have done an ERCP, very likely it be hemophilia, or if the patient had a pancreatic pathology and done an ERCP for that, then it's very likely to be a hemosuccus pancreaticus. Both these situations are treated very conservatively, as I told you. They won't need any dramatic treatment. Suppose if they are very significant, then you can do something on arterial embolization. Otherwise, you don't need any much treatment for them. So once again, bleeding from ampulla of Vater as a source of UGA bleed, two reasons. Either it could be hemophilia or could be hemosuccus pancreaticus, typically identified by a side viewing endoscopy. Suppose if there is a biliary pathology and you're getting a bleeding from ampulla of Vater, think about hemophilia. Or if it's a pancreatic pathology like pseudocyst, and for that, if you have done an ERCP and after that you are getting a bleeding from ampulla of Vater, think about a hemosuccus pancreatitis. It's a very rare cause of UGA bleed. But the eighth one, potentially very, very dangerous among all, that is aortoenteric fistulas. Aortoenteric fistulas, which can be primary or it can be secondary aortoenteric fistula. But in exam, the usual thing is secondary aortoenteric fistulas, which are very common. So usual history in exam will be a post AAA repair. After abdominal aortic aneurysmal repair, like you might get this aortoenteric fistulas, and after that you can get a massive UGA bleeding. So which is the common location for aortoenteric fistula? Can anyone tell which is the usual location based on anatomical knowledge? Can you tell which part of the duodenum is very likely to be engaged in this formation of aortoenteric fistulas? Of course, it's duodenum. I mean, I told you already which part of the duodenum is what I'm asking. It's D1, D2, D3, or D4. So which is the part of duodenum that is very commonly related to aortoenteric fistulas based on your anatomical knowledge? It's not D2, by the way. It's D3, most commonly located in the third part of the duodenum. So that is the area which crosses the aorta. If you remember, so if you take the duodenum like this, so from the pylorus it starts, and the first and the second part, that this is going to be the first part, this is going to be the second part, and this is going to be the third part of duodenum. And if you take the anatomy, if you see the aorta will be something like this. So it will be going something like this. So this is how the aorta will be. So most of the time it forms a communication here, especially, spontaneous primary aortoenteric fistulas are quite rare. Usually happens as a result of AAA repair, that is aortic aneurysm repair using a graft. So what is the characteristic timing? Usually 3 to 5 years after. 3 to 5 years after a AAA repair, you might encounter this kind of complication. Clinical feature wise, usually there will be a transient initial self-limiting bleeding. First, initially they won't bleed too much. There will be a warning bleed, warning self-limiting bleeding. Then it will be followed by a massive bleed. exsanguinating bleeding. If you pick up but during this time itself, it's not a problem at all. You might save a lot of patients, but once they develop that massive bleed, most of them will be hemodynamically unstable and it's very difficult to find out. Usual diagnosis based on CT contrast. So just leaking of the contrast from iodine to the duodenum itself is very characteristic, and you can easily find out the iodoenteric fistulas using that. And there is absolutely no role for endoscopic management. You have to definitely take the patient for surgery. So there's no doubt about that. So this is how you diagnose a iodoenteric fistula. But in exam, massive UGA bleed, patient hemodynamically unstable, history of AAA repair. Think about iodoenteric fistulas. Most common location is the third part of the duodenum. So then we have only one thing which is left we have not yet discussed, that is variceal bleed. How will you manage a variceal bleed? Even though this is the most common vascular cause of upper gastrointestinal bleeding in the emergency, and at the same time, second most common cause of upper gastrointestinal bleed, which I've discussed already, and how we are really going to manage a variceal bleed is the question. So whenever the patient comes with acute variceal bleed, when you suspect a variceal bleed, any patient with history of liver disease or portal hypertension, if they present with UGA bleed, is equal to variceal bleed unless proved otherwise. Or if the patient has ascites, patient has pedal edema, and they come with upper gastrointestinal bleed, of course, I'm going to take that as evidence of liver disease or portal hypertension, and I'm going to take it as a variceal bleed unless proved otherwise. So in exam, any liver disease, maybe they may not give a direct history of liver disease, or patient, they might give a history of probably yeah. Okay. So it could be any history of UGA bleed in a patient who's having any stigma of liver disease. They might not give, direct history of liver disease. So they might give an indirect history of liver disease, like patient is having a jaundice, or patient is having ascites, or patient is having something else. So they might give some history like that. So in that patient, any patient, if they're coming with upper gastrointestinal bleed like hematemesis or melena, of course, I'm going to take it as a evidence of variceal bleed unless proved otherwise. So now you know it's a variceal bleed. So it's a probable variceal bleed. So what do you do next? So first of all, you have to give supportive management. Plus at the same time, all patients should receive a upper gastrointestinal within 12 hours. Within 12 hours, they should receive endoscopy or ASAP. So as soon as possible after stabilization, anything is fine. So either they should receive within 12 hours, or if the patient is hemodynamically unstable, then they should receive as soon as possible once the patient is hemodynamically stable, after stabilized with some supportive management. So what are the supportive management you're going to give is the question. Most of the times they will ask you. One is transfusion of blood products, which is very important. So what are the transfusions that you can try? So first of all, HB is very important. And what is the transfusion threshold here is also very, very important. So hemoglobin less than 7 is the indication for giving a PRBC. Otherwise, you don't really do a PRBC. Hemoglobin less than 7 is the number one indication. Remember, if hemoglobin is more than 7, you don't transfuse PRBC, because the target hemoglobin is here 7 grams per deciliter only. Any too much of hemoglobin or too much of transfusions can adversely affect your portal pressure, can increase the portal pressure, and it can result in more bleeding. So don't do overzealous transfusions or avoid overzealous transfusions. Just maintain a hemoglobin of 7. That is more than enough. No need to maintain hemoglobin of 10 or 11 or something else. And second is about the IV fluids. As far as IV fluids is concerned, you have to maintain a urine output just more than what is required. That is more than 0.5 ml to 1 ml per kilogram per hour, or typically you can maintain it more than 50 ml per hour. That is more than enough. So this is the target. So you have to maintain adequate urine output, and again try to avoid too much of IV fluids, because they might result in more volume overload state and more portal pressure and more bleeding subsequently. And not only PRBCs, even you can do platelet transfusion. When you do platelet transfusion, only if the platelets are less than 50,000, because the patients are active bleeding. You can give platelets if the patient platelets are less than 50. Remember, you know what are the indications for transfusing platelets. The universal indication, I'm not telling something new. The platelets are less than 20,000, you can transfuse platelets. Or if the patient is having platelets of 20 to 50,000, plus if they're having active bleeding, or if you're going to undergo for some procedures, if you're going to take for some surgery or some procedures, so then even at a threshold of 20 to 50, you can transfuse platelets. So all patients having platelet count less than 20,000, or those are having less than 50,000 with evidence of active bleeding, or if they are planning to be taken for some surgery or some procedures or interventional procedures, then you can transfuse platelets. The same thing has been given here. Because the patient is having an acute varicose bleed here, the threshold becomes less than 50,000. So it's not 20,000 here. So it's like universal indication for transfusion of platelets only. As I told you previously, all patients with varicose bleed will receive antibiotics because there is a high chance of developing spontaneous bacterial peritonitis. So you have to give a broad spectrum antibiotics. Typically, we prefer a ciprofloxacin or probably a levofloxacin, or even you can give a ceftriaxone or maybe a piperacillin tazobactam. So any one of these drugs may be ideal, and you have to be giving for at least 5 to 7 days. This is to reduce the risk of spontaneous bacterial peritonitis, which is high in patients with upper gastrointestinal bleed and cirrhosis, which we have discussed yesterday itself. And we'll be giving some vas-active agents. So these vas-active agents are given to reduce the portal pressure. So we know what are the vas-active agents. There are two vas-active agents, terlipressin and octreotide. Any one can be given, terlipressin and octreotide, which has to be given for at least 3 to 5 days. Please understand, terlipressin is the preferred drug because according to many trials, this is the only thing that reduces mortality. Octreotide reduces bleeding, but there is no evidence that octreotide directly reduces mortality, but terlipressin reduces mortality. So that is the reason why when you have a choice between terlipressin versus octreotide, it's always better to prefer terlipressin. So that is the one that's been shown in trials to reduce the mortality, apart from reducing the portal pressure and UGA bleed. Octreotide does reduce portal pressure and does reduce UGA bleed, but it's not associated with reduced mortality. So that is the reason. So these are the 4 points that you need to know for stabilization. So usually I used to tell my juniors to remember as TIVA. So this is what I used to, like ask them to remember as. So what do you mean by TIVA? T for transfusion, I for IV fluids, V for vas-active agents, A for antibiotics. So these are the 4 steps, TIVA. So transfusion, IV fluids, vas-active agents, and antibiotics. Clear. So now once you are stabilized, so you're doing an endoscopy. So after stabilization, you are going to take the patient for endoscopy. So in the endoscopy, whether it could be a esophageal varix, which is the most common form, or it could be a gastric varix. This is the second most common, but it's rare. But remember, gastric varix are less common, but it's very difficult to control. It's not very easy to control a gastric variceal bleed, but esophageal varices are common. At the same time, it's very easy to control the bleed in esophageal varices. So what is the next step if they ask you, once you know it's an esophageal varix, you're going to do something called EVL. Everyone knows what is EVL. This is called endoscopic variceal ligation, otherwise called as VBL, variceal band ligation. You can call it anyway, otherwise referred to as EVBL. It's called as endoscopic variceal band ligation or simply endoscopic variceal ligation. Clear? So there are 2 possibilities. Either EVL can be successful in controlling the bleeding. EVL can be a success where you have controlled the bleeding, or EVL can fail to control the bleed. So if it is successful, then after that, there is a lot of steps, but once it's successful, you are going to take the patient for secondary prophylaxis. For example, you will start with propranolol, which you have discussed yesterday. It's one of the important drugs for secondary prophylaxis to reduce the portal pressure subsequently. Suppose if it's a failure, so then what you will do is you're going to do a repeat endoscopy, try one more time. If it's successful this time, then again, I'm going to take the patient for secondary prophylaxis. If it fails, one more time. So if you're encountering a failure, then you are going to take for TIPS, because uncontrolled variceal bleed or a failed endoscopy in controlling the variceal bleed, the next step is always the TIPS to reduce the portal pressure, because substantial reduction in the portal pressure are going to achieve with TIPS only. And to take for TIPS, it's not an easy thing. So it needs some arrangements, and you need to shift to a different center. So till that time, you need to stabilize. So there is some interim stabilization. So there is something called interim stabilization. So till you take for TIPS, you can do something called interim balloon tamponade. It's called interim balloon. So you can do something called a balloon tamponade till the TIPS is done. So interim balloon is typically done with 2 types of balloons. One is called as Sengstake Blakemore tube, that is called an SBT, and next one is the Minnesota tube. So there are many different types of tubes, and Linton-Necklaus tube is also there. So many different types of tube. Then Linton-Necklaus is there. Lintner class tube is also there. Any one of the tubes you can follow. Let me show you the picture of that. Lintner class, SBT, and the Sengstaken-Blakemore tube. All these three tubes are used for balloon tamponade. But remember, it's only interim measure. It's never a measure of a permanent thing, because most of the tubes, if you use for more than 24 hours, they cause rebleeding because of the necrosis of the esophagus. So tamponade should never be applied for more than 24 hours. Within 24 hours, you have to take the patient for tips. That is the ideal. So you cannot maintain the patient for long. So this is an example of the tubes which I've been showing, which I've been telling. So one is the Lintner class, and second is the SBT, and third is the Minnesota tube. So very commonly what we use is the SBT, Sengstaken-Blakemore tube. So Sengstaken-Blakemore tube, if you see, it has like 3 ports will be there. So if you see closely, you will see the 3 ports in the Sengstaken-Blakemore tube. And we have 2 balloons. The names are there here. One is the esophageal balloon, and second is the gastric balloon. And if you take Lintner class tube also has 3 ports in it, but it will be having only one balloon, that is gastric balloon, which means Lintner class tube is specifically designed for treating the gastric varix. But Sengstaken-Blakemore tube can control both esophageal varix as well as gastric varix. And finally, if you see the Minnesota tube will contain 4 ports. So that is how you differentiate. Minnesota tube, if you see closely, it will contain 4 ports. It's not the 3 port. And this also contains both the esophageal balloon as well as the gastric balloon, so that you can control both esophageal as well as gastric varix. So final take home point. So how will you identify in exam whether it's an SBT or Minnesota or a Lintner class? Remember, Lintner class will have gastric balloon only. It will not have esophageal balloon. And Sengstaken-Blakemore and Minnesota will have esophageal balloon as well as gastric balloon. But Sengstaken-Blakemore tube will contain only 3 ports, whereas Minnesota tube will contain 4 ports. Lintner class also will contain 3 ports. But first to see the balloon. So how much balloons are there? If you have only gastric, go for Lintner class. If you have both gastric and esophageal, go for SBT or Minnesota. Then see the ports. If it's 4 ports, it's Minnesota. If it's just 3 ports, it's a Sengstaken-Blakemore tube. So they might ask you this question. So they might ask you based on the in the image-based question session, which is quite possible. So anyway, so remember, balloon is only for the interim, which means till you take the patient for tips, you're going to give some tamponade effect to control the bleeding. So remember, this type of tips is referred to as something called as rescue tips or salvage tips, because you have not done tips as a primary procedure here. You have done tips as a result of a failed endoscopy. So you have tried endoscopy, it's failed. So because of that, you're going for tips. So that's why it's called a salvage tips or a rescue tips. There is something called a preemptive tips, which is not needed for your level, but this typically is referred to as something called a salvage tips or a rescue tips. Then you have something called gastric varices. So gastric varices are more difficult to control, very, very difficult, in fact, and it's less common. Fortunately, it's not that common. So how will you treat a gastric varix? So whenever you identify a gastric varix, it's like a nightmare most of the time. So first thing what you're going to do is, you cannot basically do a varicose ligation for gastric varix. Only for esophageal varix you can ligate. Gastric varix cannot be ligated. So you are going to give a local cyanacrylate injection, glue injection. There is something called cyanacrylate glue. So that is the first line method. This is a many times asked question. So what will you do if you're encountering a gastric varix? The most important thing to know is that you cannot ligate the gastric varix. You are trying to inject something called a local cyanacrylate glue. Alternatively, there is another thing that you can do, that is called endoscopic ultrasound guided coil embolization. You are doing EUS guided coil embolization. This can be tried for gastric varix, but the most commonly performed procedure, the most easiest, which is available in most of the centers, is local cyanacrylate glue. But EUS guided is more effective, but it's not available in all the centers, available only in big tertiary centers. For example, even in our hospital, we don't really have the endoscopic ultrasound machine. We refer to another hospital to an EUS. So very commonly what we do is local cyanacrylate glue injection. So if it's not available, then you can go for EUS guided coil embolization. So again, outcomes depend. So outcome could be successful. Once successful, you're going to start with secondary prophylaxis, or if it is failed, If you don't have a successful endoscopy, then straight away you go for salvage tips. Salvage tips, that's all. So here you don't need to repeat endoscopy because once failed, like gastric viruses already, they are difficult to control. So once even a single failed attempt with endoscopy, it's better to take these patients for tips. Maybe till you take the patient for tips, you can do a interim balloon tamponade, as we discussed previously. Interim balloon can be tried till you take the patient for tips, but nevertheless, once endoscopy is failed in a gastric viruses, it's always better to take the patient for tips, by the way. So this is how you manage a gastric varix. For gastric varix alone, there is some classification system is there. What is the name of the classification system? Because it's named after an Indian, that's why. So because it's the Indian gastroenterologist who proposed this classification. So what is the classification name, at least? Anyone knows? What is the name for the gastric varix classification? Of course, the question is for the audience. What is the name of the classification, man? Yes, correct. So that is Sarin classification. Sarin is an Indian. Sarin's classification. That's why I asked you. So he's still famous. It's a very famous gastroenterologist even now. Shiv K. Sarin. So that's his name, I guess. So Sarin's classification. Based on Sarin's classification, you have 4 different types. One is called the GOV1, gastroesophageal varices 1, where the gastric varices will be on the lesser curve. And then you have GOV2, gastroesophageal varices 2, so where you have the varices on the greater curve of the stomach. Then you have something called IGV1, that's called intragastric varices 1, where you have the varices located in the fundus of the stomach. And you have IGV2, that is intragastric varices 2, where you have a intragastric varix in the body or antrum or in the pylorus, apart from the fundus and anywhere else, body, antrum, or the pylorus. This is IGV2. So this is Sarin's classification. Based on that, you can propose a lot of treatment strategies, but nevertheless, that's not important for you. So how will you treat? Most of the time we treat with local cyanaclate glue injection. So one exception where you can actually treat with splenectomy. So that is for splenic vein thrombosis-related gastric varix. Suppose if the gastric varix is due to splenic vein thrombosis, then if they ask you what is the best treatment option is taking for emergency splenectomy. So cyanaclate glue injection is not that effective there. Suppose if the patient is suffering from splenic vein thrombosis, and because of that, if they are getting gastric varix, then the best option for that patient will be a splenectomy only, because it's a splenic vein thrombosis. Fine, I think this will settle the debate, and we have discussed on how to treat UJ bleed due to peptic ulcer, and we have seen how to treat UJ bleed due to varix as well, due to liver disease. And there is one scoring system which I want to really tell for peptic ulcer bleeds. For peptic ulcer bleeds, you have a scoring system. I think everyone will be knowing that. So that is called as a Rockall score. It's a very common question that's asked in exam. That's a Rockall score. As far as Rockall score is concerned, there are many different variations of Rockall score are there. One is called as a pre-endoscopy Rockall score. Then it's called as a complete Rockall score is there, which is used post-endoscopy. Pre-endoscopy clinical Rockall score is different, where you don't have any endoscopic diagnosis. And post-endoscopy Rockall score is what we refer to as a complete Rockall score. Usually in exam, they'll be asking the components of the complete Rockall score only. So what are the components of a complete Rockall score? Usually I used to give a mnemonic A, B, C, D, E, and pulse rate. So this is the components of the complete Rockall score. So A, B, C, D, and pulse rate. So what stands for A? A stands for age. The more the age, more the points, poor the prognosis. B stands for blood pressure, BP. Typically the systolic blood pressure. More the hypertension is, worse is the prognosis, and more is the risk of death from peptic ulcer bleed. And C stands for the comorbidities. And of course, the more the comorbidities, more is the risk of death. And remember, which is having more points in the Rockall score? Which organ failure is having more points? That is renal and hepatic failure has more risk of death compared to that of cardiac failure. Remember, cardiac failure in Rockall score carries only 2 points, but renal and hepatic failure in Rockall score carries 3 points, which means when you have a renal or hepatic failure, you have a higher risk of death compared to the cardiac failure. So this is a question that's been asked long back in the PGA exam. And D stands for diagnosis. What is the diagnosis that you're making in the endoscopy? So suppose if you don't have any problem at all, the score will be 0. Or if you have only just a Mallory-Weiss tear, the score will be 0. Malignant lesions will carry a score of 2. All other benign lesions, apart from malignancy, will carry a score of 1. So there's no score 3 in the D point, diagnostic. And E stands for endoscopic stigmata of recent bleeding, so which I have discussed according to the Forrest classification. Endoscopic stigmata. Of course, low risk stigmata carries no points, and high risk stigmata carries 2 points, not 1 point. So there's no 1 and 3 points here. So more the age, poor is the prognosis. Lower the BP, poor is the prognosis. Comorbidities, especially renal and hepatic, has more poor prognosis compared to cardiac failure. Diagnosis, especially malignant lesions, have a poor prognosis. All other benign lesions carries 1 point. No lesion means it's 0 points. Endoscopic stigmata, low risk stigmata carries no points. High risk stigmata carries 2 points. And pulse rate, more the pulse rate, which means more the bleeding is, so higher risk of death. So this is the component of a complete Rockall score. So you can remember by the mnemonic A, B, C, D, E plus pulse rate. So this is a mnemonic I used to give. A stands for age, B stands for blood pressure, C stands for comorbidities, D stands for diagnosis, and E stands for endoscopic stigmata, and plus pulse rate. Don't forget the pulse rate. So this is a mnemonic for the complete Rockall score, so which is very important for exams. They will surely ask. Rockall score is a predictor of mortality after UGI bleed. Especially, it's very important for peptic ulcer bleeds more than the other bleeds. But nevertheless, it can be used for anything and everything. Do you understand this, so that we can go on to the next topic? So I think your UGI bleed section is over. So now we'll be moving on to the next section called hepatitis, viral hepatitis. Do you understand this? Is there any doubt here? Okay. Recapping, we have discussed on the causes, and then we have moved to the management of UGI bleed, Rockall score, Forrest classification, endoscopic grading, then other sources of UGI bleed and their potential diagnostic entities and treatment entities, and how to manage a varicose bleed, how to manage esophageal varix, and how to manage a gastric varix, and that cyanoacrylate glue and all these things will be definitely asked in exam. And of course, this hemoglobin threshold is something that you have to know. So only if it's less than 7, you transfuse, otherwise you don't transfuse. So do we get it, so that we can move on to the next topic? Is anyone wants to ask any questions? Do you get it, so that we can move on to the next one? So do you understand? Yes or no? Cool. Okay. So the next thing what we need to really discuss, once again. Hello? Hello? Class. Kulama. Nipula. Permission already. I'm in class. When you come, after you come. Okay, ma'am. Okay. Okay, I'll get it. Okay. Okay. So the next topic what we are going to discuss is really important one. So on viral hepatitis, I know that you will never get a question without getting like something on viral hepatitis. So that's what we're going to discuss next. So an exam, one of the very important topics in the entire gastroenterology and hepatology is viral hepatitis only. So that too in the last 3-4 years, like so many questions are there on viral hepatitis. So viral hepatitis has multiple different things to know. Usually, in your microbiology textbooks, you would have seen a tabular column telling that hepatitis A virus causes these things, hepatitis E virus causes these things, characteristic feature of hepatitis B virus, hepatitis C virus. We have seen all this stuff, but we are going to approach in a little different way. So, I mean, you need to know the stuff from clinical practice, from clinical perspective, not from microbiological perspective. So basically, viral hepatitis causes many different things. It causes acute infection, which is something needed to be known, and it causes chronic infection. Certain viruses, not all, which has to be known. And at the same time, it can cause carrier state cirrhosis, hepatocellular cancer in certain patients and certain viruses. It can cause extra hepatic manifestations. In fact, all the hepatitis viruses has some risk of developing few extra hepatic manifestations, which are also very important. And what is the modality of diagnosis of viral hepatitis, and how to diagnose based on serological principles, and what are the treatment options available for treating this viral hepatitis. So these are the things that you need to know. As far as viral hepatitis is concerned, the first thing I'm going to tell is the acute hepatitis that they cause. So number one is the acute infection we are going to discuss. What are the manifestation of acute infection? Depending on the type of viruses. So you have different types of viruses. Hepatitis A virus, you have hepatitis B virus, you have hepatitis C virus, hepatitis D virus, and you have hepatitis E virus, and you have hepatitis G virus also has been told by some, but these are the 5 different viruses that you're going to ask. You know very well this is the only DNA virus. Apart from that, every other virus is going to be an RNA virus for that matters. And the groups that they belong to in the first place. A virus belongs to the Picornaviridae group, the small RNA virus group, the Picornaviridae, and B belongs to the Hepadnaviridae group, HepaDNA. So it means Hepadnaviridae group. It's a DNA virus. The name itself tells. Remaining everything is RNA virus. And C is belonging to the flavivirus group, which is typically the same dengue and yellow fever group. So dengue and yellow fever also belongs to the flavivirus only. D is a delta virus group, delta viridae. It's a delta agent. It's an incomplete particle. So it will be complete only if it is associated with the B virus. So it can never infect the patient itself. It needs B virus to be there for its survival. So we know that it's an incomplete particle. And D virus belongs to the calcivirus group. So this is the basic microbiology. Apart from that, we need not know anything much. So we're not going to ask much. So how the acute infection is going to behave. So remember, acute infection, you have certain characteristic phases. So one is going to be the incubation phase, which depends on the type of the virus. It's variable for different types of viruses. Then we have the prodromal phase, where patients may get some symptoms. Then they get the characteristic icteric phase. Then they have the resolution phase. Remember, even though these 4 phases are very classical of viral hepatitis, acute infection, not all the patients will follow all 4 phases. For example, some patients may not get the prodrome at all, and they directly get the jaundice. And some patients who get the prodrome may not become jaundiced at all. And some patients may not get the prodrome and icteric phase at all. They directly pass on to resolution. So it's not like all 4 phases must be classic in all the infections. So, but these are the classic things. Almost 20 to 25% of the cases usually follow this classic 4 stages, but not all patients follow all these 4 stages. But let us see what do you mean by the incubation phase. In the incubation phase, we know the patient will be completely asymptomatic because the virus is incubating. The patients are still infectious because the blood will be full of virus. And here the liver enzymes is quite variable. Whenever we talk about liver enzymes, we always talk about ALT than AST, at least for viral hepatitis, because ALT is more specific for the liver. We know that. And if you take the viral serology, if you do some serological tests, once again, it's variable. You don't know whether it can be positive or it can be negative. And what we really know is the patient will be completely asymptomatic. So that's what we know. That's a characteristic feature of incubation period. And the patient is still infectious during this period. So even they are cooking up, they're still infectious. But the serology and ALT is highly variable. They can have a liver damage, or they may not have a liver damage, or the serology may be positive or may not be positive. We don't know, depending on the incubation period. So what are the different incubation periods for hepatitis A virus? It's approximately 2 weeks is incubation period. That's the average. Can vary from 2 to 6 weeks, but the average is around 2 weeks. For hepatitis B virus, it's usually in months. So usually around 3 months is the average incubation period for hepatitis B virus. For hepatitis C virus, the average incubation period is approximately around 6 weeks. So usually in exam, whenever you see incubation period in months, it's always hepatitis B virus. Hepatitis B virus is the one that has incubation period up to 6 months, that is 180 days. But the usual average incubation period for hepatitis B virus is 3 months. But remember, usually other viruses apart from hepatitis B virus will have incubation period in weeks. Only thing that has incubation period in months is hepatitis B virus. And next, going on to the prodrome. Prodrome, typically, the patients may have flu-like symptoms. Plus or minus, the patients will have mild right upper quadrant tenderness, mild right upper quadrant pain and tenderness. That is because of the tender hepatomegaly that this viral hepatitis cause. But majority of them will have this flu-like symptoms like this fever, sore throat kind of an issue, myalgia, anorexia, some vague symptoms. And ALT will be invariably elevated in all these patients, and serology will surely be positive at this point, which means you can make a diagnosis easily in the prodromal phase if you are having a suspicion of viral hepatitis. Usual duration of prodromal phase is approximately around 3 to 5 days, where they can progress towards icteric phase. Remember, from the prodromal phase, there are many different possibilities. I mean, usual entities from prodromal phase, you pass on to the icteric phase, but it's not the case. There could be a lot of variations here. So one variation is anicteric phase, which is quite common. So which means the patient does not get jaundice at all. They straight away go to anicteric phase, which means they will have only mild prodrome. So once they go for anicteric phase, which means no jaundice here, from the prodrome, there can be different outcomes. They don't get jaundice, but the outcomes can be different. So what are the outcomes? Outcomes can be either a resolution, which means the virus can be cleared off the system, that is a resolution. Second outcome, it could be a chronic hepatitis, so which means they don't get a jaundice, but still they go for chronic hepatitis, or which can further progress to chronic liver disease, cirrhosis, or carrier state, or hepatocellular cancer. So this could be possible in certain viruses. Our third outcome is, I should write cirrhosis here. Third outcome is cirrhosis. Because of chronic hepatitis, they can go for cirrhosis plus or minus hepatocellular cancer. These are the three outcomes that are possible. From anicteric phase, they can develop either resolution, or they can go for chronic hepatitis, or they can develop cirrhosis over a period of time. And next possibility is acute liver failure. So which incidence is very rare. Overall, the incidence of acute liver failure due to viral hepatitis is less than 1%. There are some risk factors for developing acute liver failure due to viral hepatitis. One is the age. If the age is more than 40, there's high risk of developing acute liver failure. This is very true in hepatitis A virus and hepatitis B virus, especially if the patient is having background chronic liver disease. Already the patient is suffering from chronic liver disease due to something else. Like for example, patient might have hepatitis B virus causing chronic liver disease, or alcohol causing chronic liver disease. On top of that, if they get hepatitis A virus or hepatitis E virus, there is a high risk of developing acute liver failure. During the time of seroconversion, we'll be discussing more about that in some time. So what do you mean by seroconversion? Seroconversion happens in patients with hepatitis B virus, where patients will be having hepatitis B E antigen positivity. Later on, they will become hepatitis B E antigen negative. During that time, there is a risk of developing acute liver failure, which we'll be discussing subsequently. And patients who are having hepatitis B virus, if they get HDV superinfection, remember there are two things. One is HDV co-infection and HDV superinfection that can happen in hepatitis B virus patients. So whenever they get HDV superinfection, there is a high risk of developing fulminant liver failure. And apart from that, pregnancy is a risk factor for developing acute liver failure, especially in patients who are suffering from hepatitis E virus. Suppose pregnant individuals getting HIV, there is a high chance of developing acute liver failure, which is a very, very important question for exam. So normally, remember, the risk of developing ALF is less than 1%, but whenever the risk factors which I've told you are there in a patient, it increases by 15 to 20%, which means age more than 40 getting HIV and HBV has a risk of 15 to 20% of getting acute liver failure, and already having a chronic liver disease getting HIV and HIV infection on top of that has a 15 to 20% chance of getting acute liver failure. And during seroconversion, there is a 15 to 20% chance of getting acute liver failure, and HDV superinfection carries a 15 to 20% chance of getting acute liver failure and pregnant woman getting hepatitis E virus has a 15 to 20% chance of getting acute liver failure. But apart from that, the risk of getting ALF due to viral hepatitis is less than 1% only. You don't get that much high risk. And these are the outcomes. So from the prodromal phase, either they can go towards anictric phase, which has its own outcome, which means they don't develop jaundice at all, or they can develop acute liver failure and the risk factors which I have told you already. Remember, the one virus where acute liver failure has not been demonstrated till now is hepatitis C virus. Hepatitis C virus has not been demonstrated to produce acute liver failure at all. So whenever you develop an acute liver failure, remember, the most important evidence is coagulopathy and encephalopathy. As I told you, this is the most important evidence that the patient is suffering from acute liver failure. Plus, usually the patient total bilirubin will be more than 10 and the patient will have a ALT levels of more than 10,000. This is only an associated finding. This is not the main finding to tell the patient is having acute liver failure. But most of the times, whenever the patient has evidence of liver failure, the bilirubin will be more than 10 and ALT will be more than 10,000, and these are only associated findings. But the most important is always this coagulopathy and encephalopathy, which tells you that the patient is having acute liver failure. And please understand the fact this is a very important question in exam. Hepatitis C virus has never known to cause acute liver failure. They only cause chronicity, carrier state, hepatocellular cancer, cirrhosis, and all this stuff, but they do not cause acute liver failure, which is a very, very important point to know. And icteric phase. In icteric phase, the name tells it's icteric, so the patients will be having jaundice for sure. The scleral icterus will be there. The patient's bilirubin will be high. And at the same time, patients, because of the tender viral hepatitis, they will have tender hepatomegaly. Because of that, they might have that mild REQ pain that is persistent. And of course, ALT will be significantly elevated during the icteric phase. And of course, the serology will be positive, where you can easily make a diagnosis here. And resolution phase, many patients go for resolution. It's not like very few. And the incidence of resolution is variable, which we'll be seeing subsequently. During resolution phase, once again, the patient becomes completely asymptomatic. The ALT becomes completely normal. The bilirubin becomes completely normal. And the patient will develop this protective antibodies during the resolution phase. Protective antibodies. So what are the examples of protective antibodies we'll be discussing in some time. For example, anti-HBS is a protective antibody, but anti-HBC is not a protective antibody. So depending on, I'll tell you what are the protective antibodies and what are not the protective antibodies in some time. So now I told you some patients do go for chronic hepatitis. So some patients do go for chronic hepatitis. What are the viruses that are associated with chronicity? Please understand, hepatitis A virus and hepatitis E virus are not basically associated with chronicity. They are no chronicity. So they are not related to chronicity at all. And at the same time, they're not associated with cirrhosis and they're not associated with hepatocellular cancer. So there is no relationship for hepatitis A virus, hepatitis E virus with chronicity, cirrhosis, or hepatocellular cancer. It's always hepatitis B virus and hepatitis C virus that goes for chronicity. Remember, among all the viruses, if you ask, hepatitis C virus is the one that carries the maximum risk of developing chronicity, cirrhosis, cancer, everything. So C stands for chronicity, T stands for carrier state, C stands for cirrhosis, C stands for cancer. For all these things, the maximum risk is with hepatitis C virus only. But in textbooks, if you ask you, as per the epidemiological data is concerned, hepatitis B virus is the one that produces maximum number of cirrhosis cases and hepatocellular cancer cases because of the sheer prevalence of hepatitis B virus, which is very, very common. For example, if 10 cases, I'm telling as an example, not an absolute data, 10 cases of hepatitis B virus, if you take, only 2 patients, let us assume they are developing cirrhosis or probably hepatocellular cancer. If you take 10 virus of hepatitis C virus, almost 7 will develop cirrhosis and hepatocellular cancer if you don't treat, which means the risk is actually quite high with hepatitis C virus only. But if you take the sheer prevalence, that if you take the total number of cases of hepatitis B virus, it could be around 10,000. So that the incidence becomes approximately maybe 2,000. As per this example, but if you take the sheer incidence of prevalence of hepatitis C virus, it's maybe just 1,000. So you'll be encountering only 700 cases. So if you take the sheer numbers overall, hepatitis B virus dominates. But if you take the risk of developing cirrhosis and hepatocellular cancer, it's always the hepatitis C virus that has the highest risk of developing cirrhosis, chronicity, carrier, and all this stuff for sure. And the risk of developing chronicity in hepatitis B virus, 100% depends on age, directly proportional to the age of the individual. This is a very, very important point and a very important question. And maybe you can think about immunity as a very important risk factor. The lower the immunity, higher is the risk of developing chronicity with hepatitis B virus. For example, if you take newborns have almost 90% risk of developing chronicity. And if the infection is attained in infancy, 50% chance of developing chronicity. If you have children, pediatric age group, not infants or not newborns, children, pediatric age group, 20% chance of developing chronicity. If it's an adult who's getting a new hepatitis B infection, there is only less than 1 to 5% chance of developing chronicity. Clear? Most of the chronic HBV cases will be of perinatal transmission. That is very, very important. Remember, when you talk about hepatitis B virus, if you take Indian subcontinent, and especially in developing countries, the perinatal route is the usual source of hepatitis B virus. This is the most common source of hepatitis B virus, the perinatal transmission. That is vertical transmission, or especially at the perinatal time during childbirth. 90% of the newborns will go for carrier state, and whatever hepatitis B virus cases that you see in India right now, most of them will be due to perinatal transmission only. But if you take the Western world, it's most of the time due to needle stick, because of the vigorous screening there in Western countries, which is well developed. So needle stick is the very, very, very common route of getting hepatitis B virus. But in India, it's almost always a perinatal route, because in India, you see a lot of carriers and a lot of chronic cases. So most of them will be due to perinatal transmission only. 90% risk is there if you are acquiring, 90% risk of chronicity is there if you are acquiring hepatitis B virus during the perinatal transmission, and if you get the newborn infection, which is very important. Clear? So this is the table that I want you to really know. Remember, it's not just all the patients will go for all the 4 phases. Some patients may have incubation and prodrome, and from the prodrome itself, they will go towards anictic phase or ALF. From the anictic phase, they can either resolve, that's the most common route, or they can go for chronic hepatitis, or they can go for cirrhosis. Or more classically, from the prodromal phase, they can go on to the icteric phase and then back to the resolution phase. So which is also quite common, but majority of the times the subclinical infection, that anicteric phase, is actually quite common with most of the viruses. These are the 4 different phases of acute infection, and this is the natural history of all the viruses in a nutshell. If you take your microbiology textbooks, they will give natural history for each and every individual single viral infection, which is very difficult to remember. That's why I told you a single natural history, which will be helpful for understanding all the different viruses in a nutshell. So one particular diagram for every single viruses. And as a transmission is concerned, we know what is the transmission. So second is the transmission route, which is a question that's asked so many times in exam. So one is the hepatitis A virus. How it is transmitted? We know the most important route of transmission of hepatitis A virus is the fecal-oral route, primary route of transmission. And what are the things that transmit? Typically the food and the water, very, very important. Food and the water, that's going to transmit hepatitis A virus. And seafood, especially prawns, has known to transmit hepatitis A virus, the crustaceans, and person-to-person transmission. If you don't wash your hands properly after defecation. So this is also said to be one of the important routes of transmission for hepatitis A virus. And there is an evidence of some sexual transmission, especially those with MSM. I mean, whenever in infectious disease context, if you write MSM, that is men who have sex with men. So that is a gay transmission. So that is having a risk of transmission. So especially because it's carried through fecal-oral route. So men who have sex with men has a higher risk of having this hepatitis A virus being transmitted. So this is a very rare route, but a potential route. But nevertheless, the most often encountered thing as far as hepatitis A virus is concerned is the food and the water. Then we have the hepatitis E virus. Hepatitis E virus, once again, it's the fecal-oral route, which is the most common route of transmission. And most often it's the food and the water. And other routes of transmission like seafood, person-to-person, sexual has not been proven till now for hepatitis E virus. It's the food and the water, but it's the usual source of hepatitis E virus. And as far as hepatitis B virus is concerned, it's parental route, which means it could be either a perinatal transmission. Remember, that is, I mean, why I'm telling perinatal transmission, that is vertical transmission as the number one is because this is the most common route of transmission in India. And you do have this sexual transmission, which is very rare. Sexual transmission, it can happen with heterosexual people as well as gay people, men who have sex with men, both are possible, but sexual transmission is not that common in India. And parental route, I mean, other routes of transmission, like for example, it could be IV drug uses, it could be due to blood transfusion. Currently, this is very rare because of the rigorous screening of all the blood products we do right now. And it can happen with needle stick injuries, which is very common in Western countries, but in India, it's not at all common. So most common in India is always the perinatal transmission. That's going to be the most common. So parental route here, that's the most important. Then sexual route, not so common. Then we have multiple other routes like IV drug abuses, blood transfusion, needle stick. All these things are there. Clear? Perinatal is the usual route. And hepatitis C virus. As far as hepatitis C virus is concerned, once again, it's the parental route. As far as hepatitis C virus parental route is concerned, the IV drug uses is supposed to be the most common in the Western countries. Blood transfusion is still rare. And sexual route is still possible, but once again, it's very rare. And surprisingly, vertical transmission is also very rare with hepatitis C virus. But please understand, once I tell these are the routes of transmission, there will be a question that is that IV drug use is so common in India to get this hepatitis C virus? Actually, no. The one thing that you need to know is no matter whatever the routes of transmission you have identified, there is 25 to 30% cases where we don't know the route of transmission. This is especially true for hepatitis B virus and hepatitis C virus. So there is no identifiable risk factor in 25 to 30%. This is something that is ignored most of the times by students because of the more attractive things like sexual transmission and perinatal transmission. They will usually ignore this. This importance of this particular statement that 25 to 30% of the cases, especially for hepatitis B virus and hepatitis C virus, you don't have an identifiable route of transmission, which means you don't have an identifiable risk factor. This constitutes one of the important medical enigmas where despite having hepatitis B virus, hepatitis C virus, you don't really know what is the reason for the patient having an hepatitis B virus or hepatitis C virus. So this has been a very important statement. So you see a lot of hepatitis B virus and hepatitis C virus case in the community, but you don't know how they are acquired the hepatitis B virus, hepatitis C virus. That's a very important point. 25 to 30% of the cases, no identifiable routes of transmission. Very important. Apart from that, many viruses can cause hepatitis, including cytomegalovirus, especially in patients who are immunosuppressed, like transplanted people. So cytomegalovirus, you know how it is going to get transmitted person to person or sexual transmission, vertical transmission, breastfeeding, all these routes, blood transfusion, all these routes have been thought to cause cytomegalovirus transmission. And it's also a very important cause of hepatitis. But it's not a very common question in exam usually. Please understand hepatitis A virus and hepatitis E virus. Once again, I'm substantiating the fact there is no chronicity, no cirrhosis, no chronic liver disease or cirrhosis, and no hepatocellular cancer. But they can produce acute liver failure. Suppose if they ask you the most common cause of acute liver failure, I told you this statement already. In India, if you ask the most common cause of acute liver failure, it's always viral hepatitis. Viral hepatitis. And in the viral hepatitis, the most common cause will be hepatitis E virus only. But if they specifically ask you in children, answer will become hepatitis A virus. They specifically ask you in adults or probably pregnant women, the answer will be hepatitis E virus. That's the usual thing. But the most common cause of acute liver failure in India is always viral hepatitis only, without a doubt. There's no doubt in that. In Western countries, it's paracetamol poisoning. In India, it's always viral hepatitis only. So that's why this is very important. So all these viruses, except hepatitis C virus, can cause acute liver failure. All these viruses, A, E, B, all these viruses can cause acute liver failure. One exception is hepatitis C virus. Hepatitis C virus, no acute liver failure. I told you this point already. So some important points you need to know with regards to viral hepatitis. So we saw the natural history, we saw the transmission. Then we are moving on to the extrahepatic manifestations. All viral hepatitis has extrahepatic manifestations. What are the extrahepatic manifestations of hepatitis A virus, of hepatitis E virus, of hepatitis B virus, and of hepatitis C virus? Hepatitis A virus, many are there. Arthritis, they can predispose to development of adult onset Still's disease. They can develop aplastic anemia. They can develop pure red cell aplasia. They can develop interstitial nephritis. All this has been substantiated, but it's not very important for exams. Acute tubular necrosis. They can develop polymyositis, and even there are incidences of rhabdomyolysis with hepatitis A virus. So these are the extrahepatic manifestations of hepatitis A virus. For E virus, they can develop cryoglobulinemia. They can develop glomerular nephritis. They can develop pancreatitis. They can develop Guillain-Barré syndrome. GBS, and they can develop myocarditis, which has been there in multiple studies. They can develop aplastic anemia. They can develop hemolytic anemia. They can develop myositis as well. So many extrahepatic manifestations are there for hepatitis E virus as well. And for hepatitis B virus as such, the glomerulonephritis is very, very important because this is supposed to be the most common extrahepatic manifestation of hepatitis B virus. And we have discussed that multiple times in the past. And when you call it as most common, when you call it as most common, what is the type of glomerulonephritis that hepatitis B virus patients gets? We have discussed already. The most common type of glomerulonephritis is the membranous glomerulonephritis. That's very common with hepatitis B virus. We have discussed that one of the important secondary causes of membranous glomerulonephritis is hepatitis B virus. And you can get polyarteritis nodosa, which is also very important for exam. Now the incidence of PAN is very, very, very less because of the effective hepatitis B vaccination, but PAN is very important, polyarteritis nodosa. Then they can cause cryoglobulinemia, even though rare. They can cause polyarthritis. They can cause serum sickness. This is a question already. Serum sickness. Then Guillain-Barré syndrome. Then lichen planus. Bullous pemphigoid. All these are questions. Bullous pemphigoid. So many questions are there. So hepatitis C virus, once again, the most common is the cryoglobulinemia. And they can develop glomerulonephritis. And the most common glomerulonephritis you will get is, most common extrahepatic manifestation of hepatitis C virus is, of course, cryo. Cryo is equal to hepatitis C virus in exam, and hepatitis C virus is equal to cryo in exam. And the most common pattern of glomerulonephritis that you're going to get is MPGN type 1 or MCGN type 1, which is of immune complex type. So that is the most common type of glomerulonephritis you generally get with hepatitis C virus. And you can get that syndrome X. Metabolic syndrome is something you can get, which can predispose development of type 2 diabetes mellitus. Porphyria cutanea tarda. This is also a question in exam. PCD, porphyria cutanea tarda. Then you can get lichen planus. Then you can get secondary Sjogren. If you remember, and if you take the rheumatology section, I'd have given one of the important causes of secondary Sjogren as hepatitis C virus. If you go back and see that rheumatology notes, you will be seeing that one of the important causes of secondary Sjogren, dry mouth dry is hepatitis C virus. The most common cause of secondary Sjogren, of course, is rheumatoid arthritis, but the second, one of the important causes of secondary Sjogren is hepatitis C virus for that matters. They can produce vasculitis on their own. It is an infection-related vasculitis. It's there in the Chapel Hill consensus classification, but still not that important. Polyneuropathy. They can produce B-cell non-Hodgkin lymphoma over a period of time. So many extrahepatic manifestations are there. But whatever I boxed out are very, very important. So hepatitis A and E virus, usually they won't ask about the extrahepatic manifestations. But hepatitis B virus, surely they will ask you out of which three things you need to know is glomerulonephritis, PAN, and serum sickness. Hepatitis C virus, 100% they will ask you cryo, glomerulonephritis, type 2 diabetes mellitus, and porphyria cutanea tarda. These are the four things that you need to know as far as the extrahepatic manifestations of hepatitis C virus is concerned. So we know there are some antibodies that are developed as a response to the viral infection. There are different groups of antibodies are there. So usually I split the antibodies into two basically. So one is, I can call it as protective antibodies, and second is non-protective antibodies. So there are two types of antibodies that are formed. So remember, what are the protective antibodies? Protective antibodies are the ones that are formed against the external viral proteins. External viral proteins is against the viral protein coat. So surface proteins. So whenever antibodies are formed against these external viral proteins, so especially the viral protein coat, they are very likely to be protective antibodies. Usually protective means they convey long-lasting immunity. They convey long-lasting immunity. So what are the examples of protective antibodies? One is anti-hepatitis A virus antibody. Anti-HIV is a very important protective antibody. And second is anti-HBS. But usually in exams, this is the one that will be asking. So whenever you develop anti-HBS, which means it's a lifelong protection. You have recovered from the infection if you're already infected, or it's a vaccination status. You know that because it's a very important protective antibody that you get. So anti-HBS. Then non-protective antibodies are there. So non-protective antibodies usually are developed against the internal viral proteins, and they do not confer long-lasting immunity. They can provide only a partial immunity, but they do not confer lifelong immunity, or they don't have a long-lasting immunity. In the sense, what are the examples for hepatitis B virus? You can think about anti-HBC or anti-HBE. So these are the antibodies that don't confer a long-lasting immunity, or they will protect the individual only partially for time being. So, but they're not very important protective antibodies. They are markers that we use for diagnosis, but they are not really protective antibodies. And anti-HCV is not a protective antibody. It's only used for diagnosis. And you have anti-CMV antibodies, anti-EBV antibodies, and anti-HSV antibodies. All these things are non-protective antibodies because they are formed against the internal proteins. Core antigen is an internal antigen. E antigen in hepatitis B virus is an internal antigen. So they don't provide long-lasting or lifelong immunity. They are there for diagnosis. They help us in diagnosis, but they don't help the individual. They don't protect the individual from infection. Still, the infection will be there. So that's what is very important to know. So these are non-protective antibodies. So the usual two protective antibodies that you need to know is anti-HIV and anti-HBs, which are formed against the external viral proteins or the viral coat. Whenever antibodies are formed against the viral coat, they tend to be protective. As simple as that. Internal viral proteins, if the antibodies are developed against them, the antibodies are unlikely to be protective, and the infection will still be there in the individual. That's all. Now let us see about the individual viral hepatitis in detail. So one is the hepatitis A virus. And as far as hepatitis A virus is concerned, usually the seroprevalence, if you take the antibody and then identify the amount of population that is infected with virus, seroprevalence is directly proportional to age. This is the first point that you need to know. So higher the age, more is the chance of already have got infected with hepatitis A virus. Usually the common rule is the fact that approximately 60% of the population with age more than 60 will have a positive serology for hepatitis A virus, which means most of us, even in the general population, if you take anti-HIV IgG for that matters, it will be positive, because most of us would have got infected in a subclinical fashion. We not have got a jaundice, or we would have got a jaundice, but have resolved from the infection. So age more than 60% chance that the patient have already got infected with hepatitis A virus, which is a very important point. And apart from that, we know the excretion in the stools is very important. So how long the infective will be there. So that's what we call as fecal excretion. So which is going to correlate with infectivity. And what is the infectivity period as far as hepatitis A virus is concerned? So from the time of development of symptoms, you have symptoms here. From the time of development of symptoms, 1 week after developing the symptoms, like flu-like symptoms or jaundice, and 2 weeks before the development of symptoms. So this is the time of infectivity as far as the hepatitis A virus is concerned, which is really, really, really important. So which means you have a window period of 3 weeks, 2 weeks before the development of symptoms to 1 week after the development of symptoms. So this 3 weeks is the typical infectivity period for hepatitis A virus, even though in patients who are immunocompromised and patients who are neonates, very young children, have been shown to be infective for months together, like 3 months, 6 months and all, they're shown to be infectious. But nevertheless, the 3 weeks time is a very important question in exam, where the patient typically tends to be infectious. That is 2 weeks before the onset of symptoms and 1 week after the onset of symptoms. And typically, what are the antibodies that are going to develop? So antibody, I mean, serology wise, the first antibody that you will be developing is anti-HIV IgM. And this is the earliest evidence of infection, and this is the diagnostic antibody for acute infection of hepatitis A virus. Later on, once your anti-HIV IgM disappears, you will develop anti-HIV total. So we'll do anti-HIV total. So based on that, you can differentiate. So suppose let us assume anti-HIV IgM is there. Anti-HIV IgM is there, and total anti-HIV is there. If anti-HIV IgM is positive and anti-HIV total is positive, so usually this indicates an acute infection. If anti-HIV IgM is negative but anti-HIV total is positive, then it indicates a remote infection, which means the patient has recovered from past infection. Using this only, we will identify the seropositivity prevalence in the community. So this indicates a remote infection. And if both are negative, of course, it means the patient is having no evidence of current or past infection. So usually when a patient is coming with acute hepatitis, jaundice and all, the only test we do is anti-HIV IgM. If it is positive, it indicates an acute infection, because in remote infection, or if the patient does not having any evidence of infection, usually anti-HIV IgM will be negative. So that is why, to avoid the cost burden on the patient, the only investigation we do when a patient comes with acute infection is anti-HIV IgM only. We don't do any other investigations apart from that. Anti-HIV IgM is the only investigation that we're going to do. This is a serology of hepatitis A virus. And of course, the treatment is fully supportive. There is no role for any antiviral drugs. Treatment is fully supportive. If the patient develops ALF, you are going to follow standard ALF treatment. There is no role for any antiviral drugs, and there is no antiviral that are supposed to be proven to be effective in patients with hepatitis A virus. And you do have prophylaxis. Prophylaxis is there. So there are two types of prophylaxis. One is called a pre-exposure prophylaxis, then is called a post-exposure prophylaxis. Typically, for both pre-exposure as well as post-exposure prophylaxis, the most effective strategy is the vaccination. Vaccine is used for both pre-exposure as well as post-exposure prophylaxis. It's an inactivated vaccine. It's not a live vaccine. It's inactivated vaccine. So you can give in patients with immunocompromised state like HIV as well. Not a problem. The usual dose of the vaccine is you're going to give the first dose at the time of prophylaxis, and the second dose you will be giving after 6 to 18 months. So this is a standard dosing schedule. So typically we follow the 0 and 6 protocol, and but generally you can give around 6 to 18 months anywhere. So 2 doses are recommended. So for post-exposure prophylaxis, apart from vaccine, you can give hepatitis A immunoglobulin as well. Hepatitis A virus immunoglobulin as well. So hepatitis A virus immunoglobulin is available basically. The standard dose is 0.02 ml per kilogram. IM, this is the standard dose of hepatitis A virus immunoglobulin, and it has to be given as soon as possible, ASAP. And after the exposure, vaccine should be given within 2 weeks of exposure. Vaccine should be given 2 weeks of exposure. So these are the ways to control hepatitis A virus in the post-exposure scenario. So for both pre-exposure and post-exposure, you can give vaccine. For post-exposure prophylaxis, extra you can add a hepatitis A virus immunoglobulin, which is an optional thing, which is very costly, which is still available. And the dose is 0.02 ml per kilogram. The standard dose of vaccine is first dose at the time of prophylaxis, and the second dose after 6 to 18 months. So if the patient's age is more than 19, you can give full dose. If the patient's age is less than 19, then you have to give half dose of the vaccine. And these are very standard things, because many times when we sit in the OPDs, as a physician, I get a lot of cases who wants to get hepatitis A virus vaccinated, because I get a lot of foreigners who come because my hospital is located in that particular kind of scenario where you might be needing to vaccinate them. So one way, one of the important vaccines they ask for is hepatitis A virus once they come to India, because India is endemic for hepatitis A virus. But unfortunately, in India, we don't have hepatitis E virus vaccine, but they wanted to get vaccinated with hepatitis A virus. So once you want to tell the dosing schedule, this is the dosing schedule that you're going to clearly tell. And fine. So vaccine and immunoglobulin both are available for hepatitis A virus. This is what you need to know. So then you have hepatitis E virus. As far as hepatitis E virus is concerned, you have different spectrum of the disease. As I told you, the most important is the ALF, especially in pregnant individuals. Especially in pregnant individuals, there is a high risk of developing ALF, where there is 15 to 20% chance of developing acute liver failure. Acute liver failure. Or there can be other possibilities, like for example, patient can develop asymptomatic infection, or patient can develop subclinical infection. So subclinical infection is what we typically call as anictic infection, or they can develop a symptomatic infection in the form of acute hepatitis, which we have discussed already. And third thing is ALF, but in exam, usually they don't really ask about the asymptomatic and subclinical infections. Usually they will be very concerned about this ALF only, which is very common in pregnant women, 15 to 20% risk. That's why. So how long they are infectious? I told you that 4 weeks period is where the patients are, 3 weeks period is where the patients are supposed to be infectious in hepatitis A virus. But as far as hepatitis E virus is concerned, the 6 weeks period is where the patient is going to be infectious. For example, from the time of development of symptoms, 2 weeks before the onset of symptoms to 4 weeks after the onset of symptoms. This is where the hepatitis E virus will be excreted in the stools. So which means the total window period for infectivity in hepatitis E virus is 6 weeks. So, but in hepatitis A virus, if you take, it's around 3 weeks. But in hepatitis E virus, if you take, it's around 6 weeks. So this is 6 weeks window period is the one where the patient is supposed to be infectious if they are having hepatitis E virus. Remember, if the patient is having ALF, acute liver failure, there are some treatment options that has been suggested for hepatitis E virus, like ribavirin plus or minus pegylated interferon alpha. It's been proposed as a treatment option if the patient gets ALF in pregnancy due to hepatitis E virus. But please understand, this is only for research, but both agents are currently contraindicated in pregnancy. You don't give. Both are contraindicated in pregnancy. I mean, this has been proposed as a treatment option for patients who are having ALF due to hepatitis E virus. But unfortunately, because ALF in hepatitis E virus is common in pregnancy, even though it's proposed as a treatment option, both are basically contraindicated in pregnant individuals. You cannot give, but it's only theoretically that is proposed as a treatment option for ALF with hepatitis E virus. Chronic infection is quite rare with hepatitis E virus. There are some studies which show chronic infection, but as far as exams are concerned, whenever you think about hepatitis E virus, you just tell there's no chronicity, that's all. And once again, the genotype is there. It's not important, but as a one-liner previously in NEET exams, they used to ask, as far as the genotype is concerned, the most common genotype in hepatitis A virus is genotype 1. And similarly, in hepatitis E virus also, if they ask you the most common genotype, it's genotype 1. I mean, this is for India. Most common genotype in hepatitis A virus is genotype 1, and the most common genotype in hepatitis E virus is also genotype 1 only. And as far as the serology is concerned, the diagnostic point is concerned for acute infections, we use that anti-HEV IgM, which usually persists for a period of 4 to 6 months. And for remote infection, you can think about anti-HEV IgG. For remote infection, anti-HEV IgM will be negative, but anti-HEV IgG will be positive for remote infection. For prevention, prophylaxis, you don't have any vaccine that is available in India right now, but some vaccine has been developed in China and Nepal, but not globally licensed. It's not available elsewhere. Only in China and Nepal you have vaccine for hepatitis E virus, but it's not globally licensed. So now let us see the difference between hepatitis A virus and hepatitis E virus. There are some common things. Both are transmitted through fecal-oral route very commonly. Even though sexual route is there for hepatitis A virus, especially for men who have sex with men, but apart from the fecal-oral route is going to be the most common route of transmission for hepatitis A and hepatitis E virus. And both can have a spectrum of manifestations from subclinical infection to jaundice to acute liver failure. But hepatitis A virus is very common in children, whereas hepatitis E virus is very common in adults. But overall, most common type of viral hepatitis that you get in India is hepatitis E virus, which is endemic in Indian subcontinent, especially that India, China, Nepal, Burma, Bangladesh, Sri Lanka, Pakistan. So these are the areas where you generally get hepatitis E virus, which is endemic in these countries. And at the same time, ALF risk is very high if you get in pregnant women. Pregnancy, always think about hepatitis E virus when they develop acute liver failure. And vaccine is there for hepatitis A virus, and even you have hepatitis A virus, immunoglobulin is also available for hepatitis A virus. But for hepatitis E virus, vaccine is available, but with a pinch of salt only with selected areas. China and Nepal, you have vaccine. You don't have immunoglobulin for hepatitis E virus, nevertheless. And at the same time, the infectivity period is typically 3 weeks, that 2 weeks before the onset of symptoms and to 1 week after the onset of symptoms. Whereas here it's going to be approximately 6 weeks, 2 weeks before the onset of symptoms and 4 weeks after the onset of symptoms, you can have shedding of the virus. That is a period of infectivity here. So treatment is completely supportive. So here also it's supportive treatment only. But if the patient is having acute liver failure, you can try that combination of ribavirin with pegylated interferon alpha. But nevertheless, you need to know both are contraindicated in pregnancy. You cannot give. Unfortunately, most of the case of ALF with hepatitis E virus will be happening in pregnancy, and anyway, you cannot give them. So that's the sad part. But anyways, for both, including ALF, for both the treatment will be supportive treatment only. There's no much treatment that is available. So these are the final nutshell between hepatitis A virus. And the diagnosis of patients who are suffering from acute hepatitis here is anti-HIV IgM, and here anti-HEV IgM. So this is the diagnostic test that we do if a patient comes with hepatitis, evidence of hepatitis, elevated ALT, and jaundice. If you want to rule out a hepatitis A virus or E virus, you do a IgM. Cost effective, at the same time you can diagnose as well during the acute stage. So hepatitis E virus is over. Then comes the big boss, the hepatitis B virus. Hepatitis B virus. So this is going to be very, very important. And a lot of serology is there as regards to hepatitis B virus. As far as hepatitis B virus is concerned, first you need a natural history. Natural history. As far as natural history is concerned, majority of the patients will be asymptomatic, and very few patients will be symptomatic. These symptomatic patients will be very little, only 20 to 25% will be symptomatic, in the sense they will be developing acute hepatitis. Acute hepatitis, 20 to 25% will get acute hepatitis, and the course of acute hepatitis, more than 99% patients with acute hepatitis will go for recovery. And less than 1% patients with acute hepatitis will proceed towards ALF, but that's very rare. Usually you don't get. So most of the patients who get acute hepatitis and jaundice, this is the nicteric phase, which means they will present with jaundice, and most of them will recover. And please understand, the jaundice that happens due to hepatitis B virus is clinically indistinguishable from jaundice that happens due to hepatitis A virus or hepatitis E virus. So other viral hepatitis cannot be separated out. Only the serology will separate. Apart from that, the jaundice that you get in patients with hepatitis B virus or acute hepatitis you get in patients with hepatitis B virus is clinically inseparable from jaundice or acute hepatitis you get due to other viruses. That is number one. And second, patients can be asymptomatic. As far as the asymptomatic is concerned, most of them will have a subclinical anicteric course, and the outcome of subclinical infection can be multiple. In the sense, like they can go for resolution, recovery, because subclinical infection is common in almost, maybe I can think around like 80 to 85% of the, maybe I can read 75 to 80% of the patients, almost 3/4 of the patients will develop subclinical infection only. And out of that, almost many will recover. 65 to 70% will recover completely. And there are few patients who go for chronic HBV. The amount of chronic HBV is less than 5 to 10%. It's not more at all. Only very few, less than 5 to 10% overall will go for chronic HBV. And as I told you, this chronic HBV directly dependent on age, which I've told you the thing already. So infants are more prone for infants and children are more prone for developing chronic infection. Maybe you can think about immunity, or the immunity is less, so the risk of chronicity is more. And once they get chronic infection, there are three possibilities. They can have spontaneous clearance. You might think about how is it possible. Yes, some of the chronic HBV patients also can have spontaneous clearance, like at a rate of 1% per year, which means there is a chance that 1% per year they can go for a spontaneous clearance of the virus. They can eliminate the virus from the system completely. Or they can go for chronic hepatitis, which will progress towards chronic liver disease. Or they can develop, over a period of time, they can develop cirrhosis, and they can develop hepatocellular cancer from a background cirrhosis or without cirrhosis, doesn't matter. So these are the fates of chronic HBV infection. But the most important clinically relevant hepatitis B virus is the chronic HBV. This is the most important clinically relevant one, because this is the one that causes cirrhosis, chronic hepatitis, and hepatocellular cancer and all this stuff. Acute hepatitis most often doesn't create any problem. Very rarely they will cause ALF, but it can be easily treated. And patients who don't have ALF, most of the time acute hepatitis will be treated in a very supportive management only. There's no need to treat. It's only supportive management. If the patient is having ALF, acute liver failure, then probably you can think about treating them with tenofovir, TDF or entecavir. Any one drugs you can use. Either you can use a tenofovir or entecavir, which is a standard drug for treatment of hepatitis B virus. It will come through. So tenofovir or entecavir. So these are the drugs that we are going to typically use if the patient is having a acute liver failure. Otherwise, it's only a supportive treatment only. So these patients who are going to recover, they don't have any evidence of infection or they don't have any symptoms at all. So literally, we don't use any treatment at all for them. For chronic HBV, again, treatment depends on certain indications. Whether you treat or not is a big question. Again, there are some indications to treat a chronic hepatitis B virus, which we'll be seeing in some time. Which you'll see in some time. In some time, we'll be seeing about the indications of treatment of chronic hepatitis B virus. So these are natural history. Remember, very few go for acute hepatitis and most of them will recover. Very few go for ALF. And you know how to treat a patient with ALF with tenofovir or entecavir. And most of the patients will be asymptomatic in the sense, or they will be having very mild symptoms like flu-like symptoms. Prodrome will be there. And most of them from subclinical infection will recover, 65 to 70%. Very few may go for chronic hepatitis B virus. And the risk of developing chronic hepatitis B virus is directly proportional to age, which you have discussed already. Once they develop chronic HBV, very few patients can go for spontaneous clearance, approximately 1% per year. Remaining can progress towards a chronic hepatitis, chronic liver disease, cirrhosis, or even a hepatocellular cancer. And remember, chronic HBV patients need to be treated, but when you will treat is a big question. So let us think about that later on. So with this, let us go for a short break, maybe a lunch break. And after that, I'll be continuing with the hepatitis B virus. Do you have any doubts till now? So what you have studied in viral hepatitis? We have studied on the natural history of the entire infection, especially the acute infection. What are the outcomes of acute infection? And then we have studied about the routes of transmission. We have studied about extrahepatic manifestation of different viruses. Then we have seen about the protective versus non-protective antibodies in viral hepatitis. Then we have talked about the hepatitis A virus, hepatitis E virus, and the difference between hepatitis A virus and E virus in a nutshell. And then we have discussed on the natural history of hepatitis B virus. Clear? So, and most importantly, we are not going to discuss on the acute hepatitis and the recovery part. We are going to discuss on the chronic HBV infection because that is the one that is epidemiologically as well as clinically more relevant, because that is the one that is going to cause a trouble to the patient. So if you understand this, we can go for the lunch break. Do you understand? Till now? Yes. Okay, so let us come back after lunch break. We'll be back maybe after 1 hour, maybe 3 to 3:30 p.m. We'll come back. Okay, and we'll discuss the rest of the viral hepatitis, which is a very important topic because we're going to discuss on the serology of hepatitis B virus and other aspects of hepatitis B virus, which are very important, and the advancements in the treatment of hepatitis B virus and what are the cycle that hepatitis B virus undergoes during the phase of chronic infection. That's what we're going to discuss. Let us see after some time. So at 3:30, I will start the class. Let us come back. Bye-bye.